Thank you, Marjut. Good morning, dear colleagues. I have no conflict of interest to declare in relation to this presentation. What I will do during my presentation is I'll go through the changes. I'll remind you very briefly the data from landmark trials on which changes have been based. I'll present you the highlights of the current guidelines, and I'll close my presentation with questions we still have to answer. Over the years, breast cancer surgery became less extensive and less mutilating, and this is due to two main reasons. One is that nowadays we diagnose breast cancer patients with earlier disease, and at the same time, due to major advances in radiotherapy and systemic therapy, patients take increased benefit of these modalities. So, as a consequence, the scope of axillary surgery has been also changed. We can now evaluate the axillary node status with sentinel lymph node biopsy. The information on how many lymph nodes are involved is not that essential anymore in treatment decisions. We don't see local recurrence as we used to. It's quite rare. And finally, considering prognosis and treatment decisions, nowadays our decisions are mainly based in the disease burden, the biological subtype of the tumor, and of course we get great help from the genomic assays. So what do we consider axillary positive node patients? Those who are presenting with clinically positive axilla, which can be confirmed by fine needle aspiration, cytology, or core biopsy. And for those who are presenting with clinically negative axilla, the standard of care is a sentinel lymph node biopsy when we find micrometastasis or macrometastasis in the sentinel lymph node. ITCs, patients with ITCs in the sentinel lymph node are considered as lymph node negative patients. So for micrometastasis in the sentinel lymph node, no further axillary treatment is routinely recommended, as there is one level of evidence that there is no benefit for adding axillary lymph node dissection in terms of disease-free survival and overall survival. However, when we discuss that in various committees or analyze in guidelines, we are tending to agree that according to discussion in a multidisciplinary meeting, this policy could be modified in selected patients when there are factors indicating high risk of recurrence. For patients presenting with macrometastasis in the sentinel lymph node, in general, we could say that axillary lymph node dissection remains the gold standard. However, due to the data we have, this policy may be changed in certain patients with certain tumor characteristics, namely patients complying with the inclusion criteria of the ZO11 trial. In this trial, let me remind you that even though 27% of the patients in the axillary lymph node dissection arm had found to have additional positive nodes, at 6 years follow-up, there was no difference in local regional control, disease-free survival, or overall survival when patients with T1, T2 tumors, clinically node negatives, found to have 1 or 2 sentinel lymph node positives, were treated with breast-conserving surgery plus whole breast irradiation, no matter if they had axillary lymph node dissection or not. Of course, we all know that there was some criticism on methodological problems on this trial, but I'm not going to focus on that. However, I would like to draw your attention to the basic characteristics and tumor characteristics in this trial. I would like to remind you that we had mainly postmenopausal patients with early disease, small tumor size, less than 2 centimeters. The majority were ER positive, of grade 1 or grade 2 tumors, and with low tumor burden in the axilla. Another interesting point is that lobular carcinomas were representing a very small percentage of the trial population. And finally, the results of the AMOROS trial, considering macrometastasis, comparing radiotherapy to axillary lymph node dissection in patients presenting with clinically negative axilla and tumor less than 5 centimeters, who were found to have a positive sentinel lymph node. With a median follow-up of 6.1 years, the risk of axillary relapse was low in both groups. Disease-free survival rates were similar, and there was no difference in overall survival. Notably, there was a significantly lower arm lymphedema rate in the radiotherapy arm, and as I said at the beginning of my presentation, when they analyzed the impact of axillary lymph node dissection on systemic treatment decisions, they found that that made no difference at all. So we do have level 1 evidence that in this group of patients, further surgical therapy to the sentinel lymph node positive axilla can well be replaced by axillary radiation. And finally, patients who present with positive axilla or undergoing neoadjuvant therapy. We all know that we have enough data showing that performing a sentinel lymph node biopsy in patients who already had systemic treatment or who had a sentinel lymph node biopsy before neoadjuvant treatment, we have a lower detection rate and we have a higher false negative rate. So we could say that axillary lymph node dissection remains the gold standard for those patients. However, there are already guidelines indicating that even in these patients, sentinel lymph node biopsy could be offered, or as at St. Gallen lately, it is an appropriate option. So proceeding to current guidelines, we can see that ASCO guidelines adopted the results of the ZO11 trial since April last year, indicating that this stands for most patients. And NCCN recent guidelines included, again, the same criteria, but emphasizing that all criteria should be met, and also showing that no patients with neoadjuvant chemotherapy should be included. And for patients presenting with lymph nodes positive in the axilla, they should have axillary dissection of the surgical levels 1 and 2. In the EUSOMA guidelines on the surgical management of invasive breast cancer, which are coming soon, we are in the same direction, including also the radiotherapy as a reasonable option to axillary surgery. Last January in UK, there was a consensus meeting on how to treat lymph node positive patients by the Association of Breast Surgery of the United Kingdom. And there, for patients with micrometastasis in the sentinel lymph nodes, it was advised that no further axillary treatment is necessary, irrespectively of the type of surgery, breast conservation or mastectomy. And as for patients with macrometastasis in 1 to 2 sentinel lymph nodes, I believe that here it was made clear that patient characteristics as well as tumor characteristics should be taken into account before omitting axillary lymph node dissection or treatment. And of course, it was also clearly axillary lymph node dissection recommended in patients undergoing mastectomy. For patients with 3 or more lymph nodes involved, then further axillary treatment is advised. And by the term treatment, it was indicated that radiotherapy is also a valid alternative to axillary surgery. Finally, during the recent St. Gallen this year, for patients with macrometastasis, is in the same direction with ZO11, but notably patients undergoing mastectomy plus radiotherapy, 50% of the panel voted in favor of not proceeding with axillary lymph node dissection. And also, it is, there was a vote about patients with, presenting with positive axilla, where it was stated that sentinel lymph node biopsy is appropriate in order to overcome the high rates of false negative result. At least 3 sentinel lymph nodes should be found and evaluated, and even if 1 lymph node found to be positive, then axillary lymph node dissection is advised. However, despite all this, we still have a lot of things to answer, and all these are directions for future research. Considering patients with macrometastasis in 1 to 2 sentinel lymph nodes, we still have to answer what to do in patients with mastectomy without radiotherapy, or what to do in patients with conservative surgery but partial breast irradiation. I believe that for those patients, still axillary lymph node dissection should be the standard of care. Of course, there is concern for premenopausal patients with T2 tumor, presence of lymphovascular invasion or extranodal spread, and as I said before, patients with lobular carcinomas. And finally, there is a piece missing. We don't have a direct evidence comparing no further surgery to the axilla, one arm of the ZO11, to radiotherapy to the axilla, which is the second arm of Amaros trial. As for patients presenting with positive lymph nodes, there we have a lot of things to answer: axillary lymph node dissection or sentinel lymph node biopsy, if we have low axillary burden, and if we already know that we have a patient with good prognosis. And after neoadjuvant patients, what to do with patients who become lymph node negative: a sentinel lymph node biopsy, axillary lymph node dissection, or radiotherapy. And for those remaining lymph node positive, again, axillary lymph node dissection, radiotherapy, or both. So in conclusion, micrometastasis in general needs no further axillary surgery, apart from patients with high risk factors for recurrence, for local recurrence. As for the patients with macrometastasis, axillary lymph node dissection remains the gold standard, but it can be omitted in patients with good prognosis and having only 1 to 2 sentinel lymph node positive, usually luminal A tumors and of the ductal histological type. Thank you.